Hey guys, Respiratory Coach back here with you. So I have a question coming from McClinton. I appreciate you speaking up, McClinton, and throwing this out there because this is a fantastic topic for any respiratory therapists that have recently graduated within the last couple of years, all the way down to the current respiratory therapy students to continue learning and to be able to differentiate between the two and then understand what tells us what an ABG tells us versus what a VBG tells us. Okay, so that's what we're talking about today, arterial blood gases versus venous blood gases. And here we're going to break it down. Now, the first thing I'm going to do is go over the normal values, help you make that make sense. And then I'm going to get into some episodes to how you actually use this information in the clinical setting. Okay, so here we go. On my board here, on your left, I have the normal ABG values. On the right are normal VBG values. So we all know that ABG normal pH is 735 to 745. We all know that normal CO2 is 35 to 45 milliliters of mercury. We all know normal ABG PaO2, that being little AO2, not alveolar O2, but arterial O2, is 80 to 100 millimeters of mercury. And then our bicarb is 22 to 26 milliequivalents per liter. Okay, now, when we go over to the venous side, you're going to see that the pH gets slightly more acidotic, 730 to 740. You will see that our CO2 is slightly higher, 40 to 50 millimeters of mercury. Our oxygen is much lower, 35 to 50 millimeters per mercury. And our bicarb stays roughly the same at 22 to 26. So when you think about this, what you need to understand is what is happening in the body. Arterial blood goes out to the tissues carrying lots of oxygen, okay, and the normal amount of CO2, okay. Now, at the level of the tissues take that oxygen out of the arterial blood. It's given over. Okay, it metabolizes it and it gives back CO2. Okay, so this is happening constantly. So oxygen is constantly being taken and CO2 is constantly being given back. I'm going to say it one more time. Oxygen is constantly being taken from arterial blood and then it's constantly giving back. Now, when we give back, now we're talking about blood returning to the right side of the heart via the venous system. And if CO2 is given back after oxygen is taken off, then it makes sense why CO2 levels are slightly higher in a venous blood gas than in an arterial blood gas. And understanding blood gases in general makes sense why, if your CO2 is slightly higher, then your pH should be slightly lower, okay? Slightly more acidotic, okay? Now, because the oxygen is extracted from the arterial blood at the level of the tissues, then this makes sense why there's not much oxygen that returns back to the right side of the heart in venous blood, because the tissues did their job in consuming the oxygen from the arterial blood, okay? And like I mentioned earlier, bicarb stays basically the same. Those are the normal values. Now, this typically comes up when you're drawing an arterial blood gas and you go run the arterial blood gas and you question, is this venous or is this arterial? Well, the answer to that question is going to be in your patient's oxygenation status that you knew at the time in which you drew the arterial blood gas. So, if you drew the arterial blood gas on a patient whose SATs were SpO2, SATs, SpO2, not stats. Don't be a respiratory therapy student or practitioner that says stats, okay? Don't do that. It's respiratory saturation. It's oxygen saturation taken from your pulse oximeter. You always want to note that because that is your jumping point for how is my patient oxygenating. If their SATs are 98% and you go run a blood gas and your SATs on your blood gas comes back at 72%, then you know you drew venous blood. If your PaO2 is 35 with a SAT of of 70%, that doesn't match what you clinically knew from your patient, which was a SAT of 100%. Okay? So you know right now that I have venous blood. Okay? But you don't have to stop there. You don't have to just give up and say, okay, well, I guess I'll go redraw, which you probably will go redraw, but you can assume some things from that venous blood gas. First of all, if your patient's SATs are 100%, you don't have an oxygenation problem. Okay? We're going to exclude carbon monoxide poisoning right now. We're not talking about that right now. Okay? But if your patient's SATs are truly 100%, then you're probably not even drawing the blood gas to evaluate oxygenation levels. Okay? You're probably drawing the blood gas to evaluate ventilation levels. Okay? Is my patient in acute ventilatory failure? Meaning, do they have a high CO2 with a low pH, and do we need to intubate this patient? Well, if your blood gas comes back and you go, oh crap, I got venous, then take a second and look at it and just think about it and go, okay, well, let me see, what is my venous blood gas telling me? My pH is 732. My CO2 is 48. So what does that tell you about your patient's arterial blood gas? It means that you're going to go back and draw it, but you're going to get a blood gas back that's probably normal. Because if your CO2 is 48 on your venous blood gas, then your CO2 is going to be less than that on your arterial blood gas. Maybe it's 41, maybe it's 42, maybe it's 43, I don't know. If your pH is 7.32 on your venous blood gas, then when you run that arterial blood gas, because there's less CO2 in that arterial blood, then you know your pH is probably going to be 736, 737, 738. I don't know. There's a formula for it, but it doesn't matter. We don't use it clinically at the bedside. It does matter. What matters more is understanding the relationship between just being able to critically think through it and analyze it. Okay? If you're going to carry around a calculator and Henderson-Hasselbalch every single thing, then good for you. Okay? But that's not typically the practice, okay? I don't need a calculator to tell me Henderson-Hasselbalch what my pH is going to be. I can pretty much look at it and assess and go, okay, my venous blood gas is within normal range, which tells me my arterial blood gas is probably going to be in normal range, okay? If you get a blood gas that you run and you go, crap, I think I got venous, right? Because your patient's SATs were 98%. And you run the blood gas, and you get an SaO2 of 68%, then yeah, you probably got venous, okay? If your pH on your venous blood gas is 7.10 and your CO2 is 70, you're probably going to intubate that patient relatively quickly because their arterial blood gas is going to show a slightly higher CO2. Not much, just slightly. And it's still going to show with an acidotic pH. So your arterial blood gas, when you go back and redraw it, is probably going to come in around 715 with a CO2 of 65. And in that case, you're probably going to have to intubate that patient. Okay? Now, the only other thing I want to tell you about venous blood gas versus arterial blood gas is that this is one of my pet peeves. People draw blood and they think they get venous blood. They say, I think it's mixed. Let me tell you something. There's only one way you get mixed blood from a place that we draw blood gases. And that is that if you hit a vein and an artery in the same stick. Okay? Other than that, you either hit an artery or you hit a vein. Okay? But there is no mixed blood at the peripheral sites for which we draw ABG. Okay? If you want a mixed venous sample, then you got to draw it from a pulmonary artery catheter, okay, where all the venous blood flows back to the right atrium, and we draw it as it flows through the right side of the heart. That's where you get a mixed sample from. Other than that, it's either venous or it's arterial. Stop calling it mixed, okay, because there is no vessel that contains mixed blood at the sites from which we draw ABGs. Okay, so keep that in mind. Hey, McClinton, I hope this helped. Anybody else that watched, I hope it helps. Please comment. Like, subscribe. Love to hear your thoughts. Best wishes.